Thank you.
Okay, thank you so much for that nice introduction. I'm happy to be here and really glad to speak about this really important and under-recognized problem. So Granny is doing strange things. So I'm sure you've seen some of these strange things before. But before we start, just want to let you know that we are very grateful for the sponsorship of the UH Center of Aging, the ACL, and the University of Hawaii Department of Geriatrics, as well as the HADI grant that Dr. Mishan talked about. And so to start off, I just wanted to share a case. This is actually a real case that Dr. Pia Lorenzo had a while back. But it does illustrate this problem quite nicely. Mrs. CF, she's an 89-year-old lady, Samoan, and past medical history with dementia, end-stage renal disease. She was recently placed on hemodialysis 2 months ago. She has diabetes and high blood pressure and hyperlipidemia. She lives with her daughter, Tiare, who is her primary caregiver. And the other daughter, Maria, comes around 2 times a week or so and offers some limited support. And then they come to your office today to transfer care and to seek help regarding some behavioral problems. These are new behavioral problems. At baseline, the patient is usually calm, pleasant, able to recognize her family members, and answer questions in short sentences. Around a month and a half ago, she started having distressing nighttime behavioral issues about 3 times a week. She would believe she was up in a tree and afraid to fall off. She would scream for help and shout, "I'm falling, I'm falling," despite repeated reassurances that she was safe. And she would call out for her daughters, but then when they came, she would not recognize them. She tried to hit them. She would accuse them of being imposters. They would tell her who they were, and it would just go on all night until the patient fell asleep around midnight. And by the next morning, she would be a little bit better, and by the next evening, she'd be back to her baseline. But of course, this all started again, right, the next day. So Miss CF became so agitated during one of these episodes that she once fell off of her chair, and they took her to the emergency room at that time, but no acute issues were found, and they sent her back home. The daughters didn't know what to do. So Maria had to move in temporarily due to these behavioral issues, and they were at their wits' end what to do, and they were really having trouble coping between the two of them. On further questioning, it appears that the behaviors followed a pattern. They would occur on the evenings after each hemodialysis, Monday, Wednesday, and Friday. Her daughters do not accompany her to dialysis, and the transport company takes the patient and escorts her back home. So how does delirium present? You've seen delirium before. You can see disorientation, sleep changes, their speech might be different, either rapid or slow, hallucinations, delusions, easily distracted, restless, could be like lethargic or alternating with being hyper alert, being apathetic, just lying there doing not much, passive and mute, awake or oriented or aggressive. So it can present in many, many different ways. In fact, there's different categories, right? There's hyperactive delirium, which people recognize quite readily, right? Because if they're suddenly hitting you, that's, something's gone wrong, definitely. But sometimes it presents hypoactive delirium, which they just sit there and they're very, very quiet and they don't say anything. They're quiet as a mouse and it's no trouble to anybody, so people basically ignore it. Or it could be mixed, right? And you can see like some of this as lethargic and hyper alert, right? So they kind of alternate between those two, within a couple of hours or something like that. So delirium can present in many different ways. But the key actually is that it's different and it's new. So what is delirium according to the DSM-4, which is a disturbance of consciousness. There's cognitive changes and perceptual disturbances that's not quite explained by dementia. Rapid development and fluctuation in symptoms. So the symptoms you saw earlier, they change and they fluctuate. And there's an etiology. Now, this is a kind of a difficult, this is a psychiatric definition, so it's a little hard to determine. So more easily to determine is something called the confusion assessment method, which is very easily done by anybody. And so we sort of mapped it out here. This is actually from the American Geriatric Society GEM toolkit, where they mapped out the DSM criteria with the CAM, which is Confusion Assessment Method. And basically, the CAM is criteria 1 and 2, and then either 3 or 4. So the first criteria and the most important one is the acute change in mental status and fluctuating course. So something happens suddenly, and now it's very strange, because this is not the usual behavior, it's abnormal, and then it fluctuates, comes and goes, just like this lady, right? Some days it's on, some days it's off. What is going on? Dementia should not be fluctuating, right? Inattention. They have trouble paying attention. So somebody with dementia, they may be forgetful, but they may be paying close attention, but they're just not registering. But somebody with delirium can't focus, they cannot pay attention. So asking them to do things like saying the days of the week, forwards and backwards, requires quite a bit of attention. And that's a good test. Or even the months of the year, forward and backwards. And then either 3 or 4. So what is 3? Disorganized thinking. So that is a patient starts talking crazy. Basically, the words are rambling, they're illogical, they kind of just a flow of ideas, and they're switching from subject to subject, they're paranoid, delusional. That's the disorganized thinking. And then the last one is altered level of consciousness, where you see that they're just slumped over, sleeping cannot arouse them, versus then they're hyper alert all night long and they're not sleeping. So that is the changes in the level of consciousness. Okay, and I guess one way you could remember it is the acronym AIDA, right? So it's acute change, inattention, disorganized thinking, and altered level of consciousness. And this is a very sensitive and specific test for delirium. Okay, how common is delirium? I think most of us see delirium, especially if you're in healthcare, you've seen delirium definitely in the hospital and in the post-acute care setting. In the hospital setting, it's known, very common. Inpatient, about 25 to 33% of hospitalized patients have delirium, among those over the age of 70. If you have cardiac or hip surgery, the prevalence goes up to 50%. Half of those people have delirium. If you're in the ICU, you're in worse shape, because more than 75% have delirium. And if you're at the end of life, up to 85% exhibit delirium. And then, of course, these folks get discharged from the hospital to the rehab setting or the post-acute setting. And upon discharge, a whole bunch of them still have delirium, at about 45%. So their delirium, if they had it, is starting to clear, but not everybody clears by the time they leave, because, the hospital stays are pretty short. So about 45% still have it upon hospital discharge, going to rehab or subacute, or even going home. 1 month later, 33% are still delirious. 3 months later, 26%. 6 months later, 21%. So while people say that delirium is transient and it's not permanent and it's due to some medical illness, it is actually not so transient for some individuals. There are some in which they have, we call persistent delirium. It goes on for months. It takes a long time to clear. So then the other question is, so how often is delirium in the community? Well, obviously, if you've been in the hospital and then you got transferred to the nursing home, and 6 months later, 3 months later, you're probably home by then, but you may still have some residual delirium, right? So those who go home with delirium, but actually, I think that it's even more prevalent than we realize, because it's probably under-recognized. Case in point, who shows up to memory clinics, right? People with behavior problems or people with memory problems. Something isn't right with mom's thinking. I better take them to the memory clinic. And so this Dr. Hasegawa did a study looking at the prevalence of delirium among outpatients going to the memory clinic for delirium and for dementia, and turns out that about 20% meet criteria, the CAM criteria for delirium. And then among those after treatment of delirium, then go on and take a look and say, oh, actually, you know, there's about 18% ultimately have Alzheimer's, or about 43% have vascular dementia, 39% have Lewy body dementia. So based on referrals to memory clinic, you know, there's actually a huge chunk of them who actually present with delirium. Where else do they go? They actually go to the psychiatry office as well. They go to outpatient psychiatry clinic because they think, oh, no, this is a psychiatry problem. It's a behavior problem. And so they present there, and lo and behold, there's a segment of those that meet criteria for delirium as well. And among those cases, what they find is that 68% of those cases are actually drug-related. You change the drug and they get better, right? Or 61% due to infection, and 50% due to metabolic endocrine disturbances. Now, these don't add up to 100% because a lot of times it's a mixture or a combination of several factors that add up and tip the patient over into delirium. What are causes of delirium? Well, it's great. Delirium has a nice mnemonic called deliriums, so easy to remember. Drugs, right? As we mentioned before, that's kind of the number one problem. Electrolyte, metabolic, and endocrine disturbances, that's the E. Lack of drugs or withdrawal. So if they're, you know, on routinely taking alcohol or something, and they suddenly stop, you know, that can also tip people over. Infection is another really big one. R is retention, that is urinary retention, or, you know, constipation. Ictal, after seizures, intracranial problems, things within the brain, right? U is undernutrition, underhydration, like dehydration, right? That can also cause delirium. Problems with myocardium, your heart or your lungs causing poor oxygenation that goes to your brain can also cause delirium. So people with CHF typically present with delirium as well. And then, of course, subdural hematomas or surgery. Surgery in and of itself will precipitate delirium. So let's go to the most common causes, right? So the number one, as we saw earlier, right, the number one problem is drugs. So anticholinergic medications are the worst offenders. These are classic anticholinergic medications that cause delirium. Things like benztropine and which is cogentin, which is used for Parkinson's disease. First generation antihistamines like diphenhydramine, which is Benadryl, which is why we actually recommend other antihistamines. Oxybutynin, which is for bladder spasms, or H2 blockers are things like Pepcid and Zantac, that type of thing to block acid in your stomach. These are all over the counter. Many of these are over the counter, right? The H2 blockers. So you have to watch out for that too. Other medications like low potency antipsychotics, paroxetine, which is SSRI, antidepressant, and tricyclic antidepressants. I'll talk about that a little bit more in the next slide. Okay, these are other classes of drugs that can cause delirium. Certain classes of drugs like meperidine, which is Demerol, is classic for having higher rates of delirium. Antibiotics like the commonly used ciprofloxacin or the related family quinolones, and the other one is cefepime, which is maxapine. I have folks that are on maxapine, they go crazy, and then you have to switch it. As I asked the ID doctor, can we please, is there something else we can switch it to, because these can really worsen delirium or precipitate it. Anticonvulsants, the benzodiazepines, dilantin, carbamazepine, Tegretol, those are also classes of drugs that can precipitate delirium. As the muscle relaxants, the cyclobenzaprine, that's actually quite anticholinergic as well. Lithium, hypoglycemics, right? If your sugars are too low, that can make people delirious as well. And of course, corticosteroids, when you put people on steroids and they have this, what we call steroid psychosis, that can precipitate delirium as well. Less recognized, but I've definitely seen it, is when people get started on NSAIDs like naproxen and ibuprofen and Celebrex. Their brain doesn't work quite as well, especially if they're on high doses and longer periods of time. Not everybody, but I've seen a few patients that they come delirious with that. Anti-Parkinsonian meds are also are dopaminergic and also can precipitate delirium, in addition to the anticholinergic aspects. Cardiac meds, clonidine and calcium channel blockers are also some of the culprits that are more common among the cardiac meds family. So if I get a giant list of cardiac meds with polypharmacy and I see these meds on there, I would try to minimize those if possible and find alternatives. Herbal preparations, okay, and then the antidepressants, which includes both the tricyclic antidepressants, which are the kind of the more common classic ones, nortriptyline, desipramine, and the SSRIs like Zoloft and Paxil, those kinds of drugs, are also common precipitants for delirium. So when you have somebody with delirium, you've got to help them recover. You've got to remove the offending agent and replace it with something else that is less prone to cause delirium. That's one of the biggest things that geriatricians do. We go through the medicines and we comb through them. Okay, number 2, infection. I think this is the one that people kind of recognize most easily. These are the ones that kind of present to the emergency room, right? It's the urinary tract infections, pneumonia, and sepsis. They may not, in fact, a lot of older adults, they don't mount a fever response, or their immune system isn't all that strong. And so the way they present is not with fever. They present with change of cognitive status, and they suddenly like behaving strangely, unable to do stuff, or start, having being aggressive or more passive or something like that. That's how they present in elderly patients. Often the first sign of infection. So whenever we always make sure we look for any potential sources of infection, look at their history and say, look, have they presented like this before in the past? Actually, some of the kids, the patients, kids often know that they say, mom's being strange again. The last time this happened, she had a urine infection. Can you check, right? They may have a respiratory problem. Last time this happened, they had, congestive heart failure and MI, So look at their history as well. And with regards to sepsis, actually a change in mental status is one of those QSOFA criteria for early detection of sepsis as well, in addition to, of course, changes in vital signs. Okay, metabolic problems is the number 3 problem, very common, right? They may have anemia, dehydration. How many of you folks have seen folks, become dehydrated and then their brain's not quite working very well. They start being passive and slumping down, tired or becoming more angry or resistive, right? With just from dehydration. Abnormal chemistry, so checking those sodium, potassium levels, glucose levels, right? Hypercalcemia can also cause that, and thyroid issues. So always be checking, get a nice blood work to evaluate that. So as you can see, with the mnemonic, the deliriums, mnemonic, and with these top 3 offenders, all of these are actually reversible causes of change in mental status, right? And actually failure to diagnose and treat delirium is costly. It's life-threatening. It leads to complications. It leads to loss of function and leads to loss of independence. And yet it is not recognized quite very readily. So I guess my encouragement to you is anytime you see any of these, think about delirium and bring it up to the doctor, because the way you treat it is you treat the underlying problem, whatever is causing the problem. Okay, Now, of course, treating delirium doesn't fix dementia, but it certainly fixes the exacerbation of the behavior that you might be seeing. Okay, this is a very wordy slide. This is also from the AGS GEM Toolkit regarding management strategies for delirium. Step number one is to identify any reversible causes, contributors to delirium. So, you know, definitely, and these were the top three are there, right? The medications, the infections, the fluid and balance disorders, impaired oxygenation to the brain, severe pain, sensory deprivation, elimination problems. You'd be surprised how much urinary retention and constipation or stool impaction can drive people crazy. And then, whoa, it's a really quick fix. You just disimpact them and suddenly they're all back to normal, you know, or you put in the catheter and drain the urine from the distended bladder and, oh, suddenly they feel much better and the delirium goes away. Those are kind of the more simple fixes that are possible. But yeah, you need to look at all of them because usually it's not just one, it's probably might be even a combination of those. And these must be evaluated and treated by a physician by treating the underlying cause, changing the meds, controlling the infection, or, you know, figuring out what's causing the low oxygen. You cannot get around this. These need to be seen by a physician for evaluation. It might be helpful actually if, you know, if you're the first one to catch it, or if the family member is the first one to catch it, you know, describe what it is exactly you're seeing and, you know, make note of the vital signs because that will tell a lot as well. Okay, and then, but you don't just stop there, right? Because doctors can give them the best drug alternatives or treat the infection or do whatever, but there's still a lot more to managing the delirium that they cannot do. And so I'm going to move on and talk about the other ways of managing delirium. So delirium is also dangerous because they can be a danger to themselves and to others as well. So we have to have behavioral intervention. So we have to teach caregivers appropriate interactions with delirious patients. So, you know, teach them because these, you know, these kinds of things right here, being irritable and aggressive and repetitive, calling out, accusing others, restless, abusive, these things drive people crazy, and you could act reflexively and make the situation worse by resisting them and telling them, no, that's not true, no, no, no. That doesn't work. And so we really need to teach people how to communicate with somebody with delirium as to not make the situation worse. But if absolutely needed, we can and we should go on to using pharmacologic interventions, particularly if they are a danger to themselves or to others. And of course, using the minimum doses. So one way to think about these behaviors is instead of thinking they're just out to get you and they just hate you, no, and they're out to give you a hard time, is really they're just trying to communicate and they just don't know how. Their brain is so messed up, they don't know how to communicate their unmet needs. They can't find the words, and they don't understand what's going on, and they have decreased coping capacity. So this is, next slide is the summary of non-pharmacologic behavior management strategies. So first one there is TADA. TADA is a strategy for, is an acronym for tolerate, anticipate, and don't agitate. You tolerate the behavior if it's not hurting anyone. You know what? It's okay. They can continue doing, you know, whatever they're doing if it's not bothering anybody. Anticipate. So if you could see that they're going to start revving up pretty soon, or they're going to start pulling at their line, or they're going to, then do something in advance to prevent it. You can see it coming. Oftentimes, you know, like if anybody's parents out there, yeah, have had 2-year-olds, right? You child-proof the house, right? Because you anticipate that there may be problems, and so you want to prevent it from going there. So yeah, anticipate things that might happen, and prevent it. And then don't, if it's causing agitation, causing them to get upset, just don't even go there. Don't say those things. Just do whatever to not agitate and make them worse. So tolerate, anticipate, and don't agitate. Body language is important. Approaching them from the front, speaking slowly and calmly, acknowledging them, nodding your head, you're listening, you understand them, showing affection. They understand emotions, they understand caring, and that's probably the best way to try to address them. Trying to reason with them isn't going to work. Anticipating and addressing basic needs, they're not going to be able to express if they're hungry, thirsty, hot, or cold. So you basically have to, figure that out. Offer them something to eat. Offer them something to drink. Make sure don't get too hot, don't get too cold, that they're not getting too tired, so there's this, you have to monitor all of these things for them. They're not going to be able to express it. If they have fear, anxiety, or depression, we need to make sure we address those. And the environment. If the environment is overstimulating, there's just too much noise going on in the hallway or in the room, and too many people are talking at once, so there's music and TV and somebody talking on the telephone, and the thing is beeping, that's overstimulation, and that might also cause worsening agitation. And your verbal approach is don't argue with them, right? Because logic and normal reasoning don't work when the brain's not working. So it's not going to be effective. Because even if you told them, they're going to forget in just a second. So that's not helpful. But the important thing to do is to listen to their feelings and address those feelings. So if you see, more effectively is if you see that they're anxious, then address the anxiety. Oh, you look a little bit worried, let's distract them and talk about something reassuring, right? Let's distract them and, bring a teddy bear or their favorite thing to hold or a soft pillow or, whatever. Reassure and redirect. So basically, approach them by listening to their feelings and addressing them. If they're angry, then you nod your head and you justify that, oh, I get it. I understand why you're angry, You address their feelings. And then consider activities, like, so if they're anxious or whatever, oh, let's try some music therapy. Let's get some music going on here that they would enjoy and sing along with them or whatever, or a gentle sensory stimulation. So these are common non-pharmacologic diets you can teach caregivers, staff, as well as patients and families, instead of just getting frustrated and trying to correct their misperceptions. These actually go a really, really long way, and some people are really good at it, and you can get very good at it as well. This same approaches for dementia behaviors, but also work for people with delirium. And in order to avoid the use of medications, which can worsen delirium, this is what we must do. Okay. These are some of the drugs used for treatment for agitated delirium. You've heard of Haldol, right? That happens to be a really potent drug, but it has what we call extrapyramidal side effects, which is movement disorders. But they're really, really effective. So we usually the agent of choice for something really acute and dangerous, something like that. But of course, go with the super low doses, as again, like the 0.25 or the 0.125. There are other alternatives. There are the other second-generation ones like olanzapine, quetiapine, and risperidol, which are also effective with different side effect profiles. So we choose them based on the side effect profiles. So, for example, some of the other drugs have fewer movement disorders or restlessness or something like that. And then others have less problems with low blood pressure or something. And others, like the quetiapine, are more sedating. So that one you might use, overnight to help them sleep, to get a good night's sleep. But of course, that also may, cause problems with low blood pressure. So depending on their condition, you may choose a different agent, and they're also different in terms of how long they act. They're once a day dosing, Q8 hour dosing, or whatever. Your last choice, of course, is Ativan or lorazepam, which is a benzodiazepine, and basically it doesn't do anything but sedation. And basically when you give somebody lorazepam, you make them sedated with delirium instead of active delirium. So you don't really get to the problem of it. And also it may cause paradoxical disinhibition, and so if you give it to them, they actually might get more agitated. So they go to sleep and then they rebound and they have worse symptoms than before. So this is actually not recommended at all. But if they are, being super dangerous and throwing and hitting, you give them a shot. But I'd rather give them the Haldol before I do that Ativan. Ativan is not good unless they are having alcohol withdrawal or something like that. Okay, and then, here is also very, very important. A person with delirium tends to develop urinary incontinence, tends to have, be restrained, not to pull out lines or catheters or things like that. And then they're unsafe to walk, and so they try to keep them sitting or lying in bed, or they're just very high falls risks. People with delirium, because they may become passive, they may develop ulcers, pressure ulcers. They have sleep disturbances and get sedatives to get them to sleep at night and not keep everybody awake all night long. And feeding disorders, if they're not eating properly and they don't know quite how to eat, or they're aspirating, they will have problems with dehydration and malnutrition. And so instead of waiting for these things to happen, for a person with delirium, right from the get-go, right from the outset, we need to anticipate and prevent or manage these problems. So if the person has delirium, we need to implement a scheduled toileting program. If they're unable to toilet, then we have to, change them very frequently to prevent this, because they're not going to tell you that they went to the bathroom, right? And you don't want to have the hygiene issue with the skin breakdown problem that goes with that. For, preventing immobility and falls, and maybe we need a true person assist to, get them to sit up or to, get out of bed and sit in a chair, or even walk short distances. Make sure that we prevent the deconditioning. Pressure ulcers, they're not going to tell us, so you need to reposition frequently and monitor your skin for pressure points. People can develop pressure ulcers not just lying in a bed, but also even sitting in a chair. So that needs to be looked at as well. Sleep disturbances is trying to implement a non-pharmacologic sleep protocol as best as possible and avoid sedation. And then feeding disorders, assist with feeding, use aspiration precautions, provide nutritional supplementation to prevent this malnutrition that happens oftentimes when people have delirium. And then, if you're working in a hospital or a healthcare provider, man, these people with delirium, they're very high maintenance in the hospital, and it would be great if we had one-to-one just to keep them safe, but that often is not possible. A one-to-one sitter is very expensive. And so I think in order to anticipate and prevent complications, we need to speak to the family and caregivers and let them know that if we want the best possible, quickest recovery and the best possible outcomes with less complications, the families should try to provide better supervision. Try to come, even if it's a couple of shifts, a few hours a day, take turns, whatever. And even when they get home, right? 24/7 supervision. That's what they need. It doesn't matter who it's from. It needs to be done. 24/7 supervision for someone with delirium. Regular toileting, frequent repositioning, and feeding assistance. Just because they came home from the hospital doesn't, and their pneumonia is gone, doesn't mean that they can feed themselves adequately or position themselves frequently to prevent pressure ulcers or to make it to the toilet on time. And that this may be needed for months because families have to plan ahead. They can't just take off from work for 2 weeks. What's the 6-month plan? We saw that 21% of people with delirium post-hospital still have delirium. Maybe not as bad as it was when they initially presented, but it's still a component is there, and they may still need quite a lot of support. And then, of course, we want them to get better too, right? So we have to work on restoring their function, not just preventing complications, but we need to restore their function. So make the environment more conducive to a normal environment, reduce clutter and noise at night, provide adequate lighting, have familiar objects, you know, have them reorient the person, you know, gently, a few times a day, but not pushing on them and not, you know, as if, you know, fighting with them or anything like that, but just try to gently reorient them. And try to, as the delirium clears, they're able to do more. So just because they couldn't do something, they couldn't feed themselves earlier, doesn't mean you have to feed them for the rest of their lives and don't give them a chance to even try again. I've seen that happen, you know, and then you're like, wait a second, why don't we try hand feeding? Maybe they can pick up something and eat, you know, try to help them progress back to function as they recover, because delirium is technically a reversible condition. Family education. We need to provide education for families about the causes and the reversibility, how to interact with them, and how the family can help with restoring function, because it's going to be the long haul part. The acute episode is over, but it's going to be the 3 months to 6 months range where you're going to be working on restoring function, walking, feeding, and engaging with others socially. And the other thing that's really important is follow the mental status changes as a barometer of recovery. So now a family member may or may not be able to, you know, do those, you know, cognitive tests, but, you know, the physician can actually follow that as well. And, you know, I've done the mini mental serially over months, and I watched the scores improve over time because their brain is slowly clearing. So, you know, and we have to keep working towards making it as good as possible. And really the support from the family and the caregivers may be required for the long haul. And if they are not able to provide that in the long haul, then maybe, you know, a care home or a skilled nursing facility may be required for a season and reevaluated 6 months later, right? But during that time where they need the 24/7 support, it needs to be realistic. Otherwise, they're going to set themselves up for some complication. Was there something I wanted to mention? Yes, the other thing I wanted to mention here is that the follow-up is really important, because sometimes delirium is that sentinel event. People don't really think that, oh, they never had dementia before this, and suddenly they went crazy. What happened? It's not uncommon. I think we saw in an earlier slide that for the folks presenting to the outpatient clinic, right, for cognitive disorders, that a lot of these folks may have underlying dementia. It may have been super mild, but something like this really tipped it over and uncovered it. And that, and so getting, once the delirium clears, you need to evaluate for dementia. Because that's, and then what kind of dementia? It could be vascular, it could be, you know, whatever, Lewy body, could be Alzheimer's or Parkinsonian or whatever dementia, but needs an evaluation. Okay, so the summary here is recognition of dementia is critical, as we saw before, right? If you don't address the infection, if you don't address the fluid overload, the electrolyte disturbance, they might die, right? It's a medical problem. It's a medical crisis. It needs an evaluation. So recognition of delirium is critical. The earlier you recognize it, the sooner it's treated, the less complications, the less problems. Delirium is common, associated with poor outcomes, and is often under-recognized. A doctor must evaluate and treat the underlying cause. We must anticipate and prevent complications, short-term and long-term, and prevent functional decline. It's not uncommon that, you know, they get very, very deconditioned, get functional decline, and then they never, ever recover. They sort of lost their opportunity. Non-pharmacologic support is preferred, but neuroleptics are preferred if needed, if absolutely necessary for safety. And prevention is the best approach. Delirium is a risk factor for dementia, and education and follow-up are very important. Okay, so open for case discussion if you have questions. But actually, I'm gonna just go back to, you're probably wondering what happened to the first case, right? What happened to Mrs. CF? What do you think happened to her? You think she had delirium? Yes, right? She meets the criteria for delirium. And what is the most common problem for delirium? Number one, right? Medications, right? So let's think about this, right? There's medications, and there's another clue here. It followed a really strange pattern. It had to do with days of the week on hemodialysis, right? And so you're thinking, maybe it's an electrolyte problem, right? Maybe the hemodialysis messed some chemicals up in her brain, and that's why she got tipped over, right? So we need to think about this, because this is going to keep going on if we don't solve this problem. So let's take a look at her medications. Okay, she's on insulin, long-acting, Galantis, and short-acting, the Aspart. She's on Lasix to go along with the hemodialysis. She's on Aricept. She's on a bunch of kidney things and cholesterol and aspirin and vitamin stuff, right? So, so what would you do first, right? Well, get labs, right? Because if your first thought is, wow, maybe she's got some chemistry issues going on from the hemodialysis, maybe we really need to check some labs on her, right? And so here are the labs taken at the office, right? Was there anything abnormal in here going on? I'm thinking, yeah, actually, not that abnormal. And this is probably what the emergency room saw. And so they wrote, and she was probably just sitting in the office just fine, and there was no issues at that time. And so, of course, the labs are okay because she was sitting in your office. She was cooperative enough to get there. So probably need to get a lab when she's kind of whacked off, right? But actually, if you look a little more closely, these aren't so normal. 98, this is a non-fasting blood sugar, right? That means she ate something before coming to the office. Why is the blood sugar 98 after she ate? What is it like fasting, right? Hypoglycemic. So, long story short, what happened here, just remember, so she's been developing end-stage renal failure for some time. And a person with end-stage renal failure doesn't metabolize medicines very well. It doesn't filter the medicines very well. And it hasn't been filtering, and the insulin probably isn't being filtered out. And so probably the blood levels of the insulin have been rising in her for quite some time, even before she started dialysis. And her sugars have been starting to drop. She probably doesn't need as much insulin as she has in the past, right? Even though she did just fine with it before. So that's something to think about. But something happened with the dialysis. And what does the dialysis do? Depending on the fluid, the dialysate, the fluid in the machine, dialysis machine, it could pull out glucose out of your blood system, as well as insulin. So if it pulls out both the glucose and the insulin, who knows? She may very well, after dialysis, be completely hypoglycemic. And nobody has checked. And nobody knows. And she goes back home by herself. You know, the transport company takes her, right? And she goes back home. And then she's feeling like she's falling. I'm falling. Probably because she's feeling quite dizzy from the hypoglycemia. So what was the solution? We was to lower. Actually, if you see here, her hemoglobin A1C is 6.8, which is actually amazing. It's great. It's quite good. That's a target that people want to achieve. We're a target. But for someone with dementia, it's probably a dangerous place to be that well controlled. And especially somebody with dialysis who is fluctuating quite a lot during dialysis. Fluctuating. So the safer thing to do is probably relax the sugar control, and reduce the doses of the insulin, as well as probably talk to the hemodialysis center and see if they can put some glucose in the dialysate to reduce the hypoglycemia that follows after dialysis, since that is her problem. So that pretty much solved the problem for her. And so she had a happy ending to that. But that is an example of treating. She had underlying dementia. Something went wrong with Granny, and she went crazy. She went strange. And then they got it addressed. And the culprit was probably both medicine and the chemistries. So, okay, I'm going to now open it up, and we'll see what people. I'm just going to put on this slide right there.
Yes. Okay. Does anyone want to ask a question of Dr. Wen? We've muted a lot of you, so you'll have to unmute yourself if you want to ask anything.
Seen anything similar that you want to share?
Yeah. Have you all experienced delirium in your work? Everyone is so quiet. I just want to say, what do you do when there's no geriatrician? Because all the things you're talking about, if you go to a primary care physician and they see you for 15 minutes, the person, how do they are able to troubleshoot like what that was done with this lady? You know?
Yeah. If they're good, they should be able to piece the puzzle together. Something is wrong. Mm-hmm. Need to check the labs and need to look at the medications and look for infections. I mean, those are the top three. Mm-hmm. So even as a caregiver or other provider, you can suggest that to the physician. The last time something like this happened, this was the problem. Mm-hmm. Are you sure that, can you make sure there's no infection or chemistry issues? Can we check a lab? Things like that.
We do have a question about how long after treatment for UTI would a person return to normal if they had normal behavior prior to the UTI?
Everybody is different. Everybody's an individual. But I've seen people get better pretty much right after the first dose of antibiotic. I've also seen people take a week. So, yeah, everybody's variable. But if you were baseline normal, you probably recover more quickly.
Does anyone want to, again, share anything about experience with a patient or a client or a loved one who had delirium? Perhaps it was dealt with well. Perhaps it wasn't dealt with well. Does anyone have anything to share about that? very quiet group. Okay, I'm going to also ask something or say something about the importance of the family caregiver that you mentioned, that their participation in the recovery at home is so important. And I've heard anecdotal stories, and I'm sure many of you have, where somebody is released from the hospital, they go home, and they don't provide 24/7 care. The person goes right back to the hospital. So in a way, this kind of attention to the family, taking it seriously, that person needs supervision, is almost a non-pharmacological intervention. Even if they have money, I know of a case where somebody did have a lot of money and could afford to get someone in the home, but just was in denial because they thought that that person would get better. Maybe somebody wants to say something now? Sorry. I thought that somebody unmuted themselves and wanted to say something. You could also chat the question if you have a question or something to share. Okay.
All right.
That's all right. You know, we would love to send you the handout afterwards. If you do have any questions, you can email me and we'll ask Dr. Wen to respond. I know some of you are logging in from Kauai. I'm curious about how, I know that you have less geriatricians there, and I'm wondering whether that's been a problem in situations like this. If you'd like to chat or say something before we sign off. Okay. Next session we have is going to be on Wednesday, March 27th. And I would just like to thank you, Dr. Wen, for again doing this for us. It's really enlightening. And again, if you're calling in and you don't know how to get this handout, please call me, Jody, at 808-295-2624. And I'll be sending everyone follow-up with the handout because they have some really good, there's really good stuff in your PowerPoint. So thanks again. Have a good rest of the week.
Thank you.
See you next month.
Okay. Bye.
Bye-bye.